Good evening, sir, and good evening, everyone. Sir, as every time, shall we just wait for 5 more minutes and start our session, sir? Is that all right with you?
Yeah, fine.
Thank you,
Let's
sir.
wait for 5 minutes.
Thank you, sir. So requesting your, please, the participants who have already joined to please send a reminder. I have already sent them a reminder in the group. So if you please just tell them that the speaker is already there and it will be nice if they can join. I see Romina Joseph from Echo India joining. So is Shweta going to join? Or are you going to be with us throughout?
Actually, I joined as a part of session observation, but I'm not sure. I mean, I'm assuming Shweta will be joining. She hasn't informed me anything.
Okay.
Yeah, I'll try reaching out to her.
Sure. No, just wanted to check and confirm.
Oh,
Thank you. Thank you.
yeah.
Good evening, one and all. This is Vinila, Program Coordinator from Hyderabad, and we have a speaker ready with us this evening. And humble request and a gentle reminder to all of you, please turn on your video cameras throughout the session. Mute your microphone if you're not speaking. If you have any questions, please raise your hand, or you can always type in the chat box. We'll read them out for you. And this recorded session will be shared with you. And please, I see most of you have renamed yourself. If you are not renamed, please rename yourself, because this is very important for the purpose of attendance. And thank you, sir. Well, it's already 7:05, and please let's start the session. And over to you, Suresh, sir. Very nice to have you again with us.
Thank you. Thank you, Vanilla. And sorry for messing up last time, because I was supposed to do this a couple of weeks back.
No issues at all, sir. Thanks a lot.
Thank you. Yeah, for the slot. And good evening, everybody. We are planning to discuss volunteers in palliative care for two aspects. What can they do, and more importantly, how can we organize them? Like, how do we get volunteers? What do we do? How do we maintain? What are the problems? For me, I've been in palliative care for more than 28 years, and all these years I've worked very closely with volunteers, like volunteer team, setting up and working with volunteers. So let's have a look at what it is. Let me share the screen. Is this visible?
Yes, sir. It started sharing. Yes.
Okay. So it's about volunteers in palliative care. Volunteers, actually, like, you have a program and you have staff, you have a budget, you have a facility, but volunteers are unpaid people who they are with you to help you. And this actually will imply participation of the community in your program, like other people who watch your program, other people who want to do something for you, who are interested in your program. So it can be two ways. They can be working within your team, supporting you. That can be one type of volunteer, working very closely with you, under your supervision, supporting you. And they can also be volunteers outside. They are not part of your team, but they work in the community. They work in other places, and they help you to either enhance your program or strengthen your program. So these are sort of outreach volunteers. So these can be two types of volunteers: to the requirement and the ethics and the way of working are different from the two types of volunteers. And so this is actually part of the public health approach that what WHO has been suggesting all the time. When they talk about palliative care, they were suggesting that, okay, let me take a pointer. Yeah, they were suggesting that like the specialist care, what is needed in a hospice, or what is needed in a specialist tertiary palliative care center in a hospital, that's needed only for a small group of people. Most of the others can be managed in the primary sector, either by the GPs or the primary health care team. But if they are supported by people in the community, people who can help, this is because, like, even if you have a very good center, even if you look after a lot of patients, most of the time the patients will be spending most of their time with their family members. A healthcare professional or a home care team cannot remain with the patient all the time. The patient will be with the family members, they will be with the friends, they'll be with the relatives, other people. So these people can influence the patient behavior, influence the patient quite a lot, and influence the care quite a lot. So what has been suggested is that you need to take them into confidence. You need to take the community into confidence, so that what you do, otherwise what will happen is your home care team will go there, you will tell something, and next day a neighbor would come and they would advise the patient in the opposite. Another relative would come, and this we all have seen, like, patient gets very multiple different opinions, and usually they are confused, And so if you have these people also, if you take these people also into confidence, if these people also know what to say, if the family members know what's the situation, what to say, what not to say, the neighbors know what to do. So this is what we call general community should have some awareness about palliative care. And why community participation? There's also another reason. You see the patient and they have multiple problems. Many of the problems are not medical. Patient may have some physical problem which you need to treat. Patient may have some emotional problem which you need to address. But there are a lot of non-medical problems also: social isolation, financial issues, no food in the house, children not going to school. A lot of issues are there, and the local community can play a major role in addressing these problems. And again, the advantage is again is that like anybody interested can help. Anybody like that, whatever be the person's background, whatever be the person's age, whatever be the person's sex, whatever be the gender, irrespective of that, if you are interested in that patient and if you want to help, you can help as a volunteer. And then because there are structured training programs also available, so one of the responsibilities of the palliative care team would be to make sure that people who are interested in helping this patient, because for every patient there'll be a lot of people interested in the well-being of that patient. This may be immediate family members, this may be neighbors, this may be old classmates. So if we can train them, at least basically orient them in supporting the patient, they can do that because they have a basic interest in that patient. And but from our side, we need to involve them. From our side, we need to train them. This is what we need to do. And what can volunteers do? These are the things that volunteers do in most places. This is what they do in my place. This is possible in your place also. They can offer social support to the patient and family. They can visit the patient. They can spend time with the patient. They can see that kids go to school properly. They can see that they can take shifts in supporting the care. A lot of social support can be offered to the patient and family. And regular continuous emotional support. Like even if you have a professional psychologist working with, the psychologist may not be available all the time. So somebody sitting the patient, listening to the patient, listening to the family, that can be a major role. If we orient them properly, if they train the volunteers in psychosocial support properly, they can be a very big asset in that area. And improve in death literacy. This is actually like what happens very often is that we don't discuss death in the community. We don't discuss death in the society. There's a lot of mystery surrounding death. People are worried about death, but we know that we all have to die one day. So this is so common, universal, but at the same time, which is not discussed, which is not looked into, which means people generally are apprehensive of death. People generally make no preparation for death. People like when they're faced with when they see that they are about to die, they are about to die in 3 months, 2 months, 1 year, they become worried, they panic. And so there is a need to discuss death in advance. There is a need to discuss not with the patient, but with everybody. Like the society need to know that, okay, we all have to die, we need to prepare. There are a lot of preparations needed. We need to face this. So this is an area where many of the volunteers work. They run what we call death cafes, informal meetings where you can discuss your worries about your own death. You can discuss your worries about other people's death. So this is improved death literacy. And then they can also spread the idea of palliative care in the community, because many people in the society may not know what palliative care is. A volunteer can easily, like, they can demonstrate it, they can tell people, they can make advocacy, and they can help. Minimum basic nursing care is also possible. They can help the family with basic wound care, and they can definitely advise the family on prevention of bed sore. How do you prevent bed sore? How do you make sure that the patient does not have any pressure sores? And help with mobility. And then there are in many places there are social stigma to cancer, AIDS. Volunteers can actually fight these social stigma in the society. And in many places like my place in Kerala, volunteers also organize local palliative care initiatives. They group together after training, they sit together, group together, they form a local group, they fundraise, and they organize a local initiatives. They can also help in advocacy. But when you say that, okay, there are a lot of advantages. There are quite a lot of advantages in involving the volunteers, and any group would do better if you have, like, if you have 10 people in your staff, or if you have 6 people in your staff, you get 10 volunteers who are willing to help us. That will be definitely good, because you don't have to pay anything. They are there to offer their services free of charge. They help you. But again, this is not happening in many places because it's not easy. This is not very easy. Because in any community, like when you approach them, there'll be existing power structures, existing ideas, existing conflicts, which also you have to know, you have to overcome. And again, why should they accept you? Like, building trust in the community it will take time. If you say, for example, you are a doctor or a nurse, and you go and go to a village or to a nearby community and tell them that I have a project, I need volunteers to work with me. They unless they trust you, they may not come forward. And the trust is not an easy thing to build. It takes time for trust to build. So these are the, like, as a professional, when you are looking for volunteers from a particular community, you need to know what is in that community, what is the power dynamics in that community, what are the power relationships in that community, who listens to whom, and then what are the other issues in that community. And also, like, you must be acceptable to them. How do you make yourself acceptable? You must be familiar to them. Over the time, they will be watching your work, and they will be, so unless that trust is built, you'll find that people will not come. And when you have a group of volunteers, again, that's different from the traditional way we work. Usually we have a team, and there will be some accountability, and there is some hierarchy, and orders are given, orders are taken, and so. But when you have a group of volunteers, because they are not hierarchical, they are not, even if they are part of the team, you don't pay them, and then so they may have their own opinion, which means they may question you. When you ask something, they would ask you why should I do this? And so if it's your staff member and the person is under you, they may do it if you insist. But the volunteer may question you, volunteer may debate with you, discuss with you, which means you will have less control over the project. Like, you will not get everything automatically obeyed. And then a community's priority can also, the volunteer may have a different priority. And if you have more volunteers, they may disagree among themselves. They may disagree with you. And then also, like, when you tell them about looking after a bedridden patient, looking after a dying patient, addressing suffering, that may be appealing to them. They may come forward. They may start working with you. When then the person may disappear after a few days. He or she may lose interest. So how do you maintain that motivation? How do you sustain? If you have a staff member, if you employ somebody, you will know that, okay, this person will be there with you, and this person will give you notice before leaving. A volunteer is not paid, and volunteer is not in your payroll. And if the volunteer feels that, okay, I'm not interested, suddenly one morning the volunteer feels that, okay, I'm not interested, I'm not going there. So this is the problem, because how do you make sure that your volunteer is motivated? How do you make sure that the project is sustainable? Because if you count on 5 of your staff members and 10 of your volunteers, you have to somehow make sure that your 10 volunteers will be there. So this is also an issue. So let's start from the practical aspect. The first thing is to get people interested. You want to start a palliative project or a healthcare project, and you want a few volunteers. So you want to get people interested. So some of the key factors, I've seen projects, volunteer projects running and failing and successful. There are 4 key factors which decide whether people will be interested in your work. One, in any community, there will be different groups of people, different types of people, different communities. For example, there will be student groups, there will be religious groups, there will be political groups, there will be clubs, there will be youth organizations. So whom do you want to address? You cannot just address everybody, because you need to decide who will be listening to you more. which group will, if for example, if you are a church goer, or if you are a religious person, and if you find that, okay, my religious community will listen to me more, that can be option. Or if you feel that the students are more active, they have more time, they will listen to you more. So first you have to decide whom do you want to address. And secondly, what do you want to tell them? If you tell them, for example, if you tell them that I have a project, you should all come and help me, they may not be interested. Why should they come and help you in your project? So what do you want to tell them? And how do you want to say this? Okay, the way you express it, the way you interact with them is also important. And then most importantly, in your eyes, who are you? Who is this guy? Who is this person coming and telling me that I should get involved? So that's also important. So we'll look at these factors once again. So the first one is whom do you want to talk to? Because so you talk about community, you talk about community from where you can get volunteers. There are many communities there. It's not a single community. As I mentioned, there will be multiple religious communities there. There will be a Christian community, there will be a Buddhist community, there may be a Muslim community, there will be a non-religious community. Then there are communities of professionals. There are nurses community, doctors community, then student community. Then various political parties can be seen as different communities. So there will be different NGOs. So you have to decide which platform to choose, because this is important. You choose the wrong platform, you'll find that nobody would come. So look at the platform and carefully select which community you want to address first. Later on, when the project develops, so later on when the volunteers get established, you will get people from other groups also. But where do you want to start? Which platform do you want to start is important. It can be an NGO, non-governmental organization. It can be a religious organization. Each one has its own advantage and disadvantage. So there is no perfect platform. You cannot say that, okay, this is a perfect platform, this will get a lot of people. It depends on your region, your influence, and also the way they work. Local government can be a platform. Political parties can be a platform. I have worked closely with many political parties because they have a lot of manpower. So when you talk to them and they listen to you, you will get volunteers. District administration can be a platform. So these are some of the examples. So the first thing is to decide which group do you want to address, and that's very important. And secondly, when you decide this, again, there are some groups already existing. There may be, for example, a church-based group. There may be a Buddhist a group. There may be a political group. There may be a club. There may be an NGO. So if you, for example, if you choose them, if you say, instead of going out to people, you go to one particular group and ask them whether they can involve as volunteers. There's some advantages and disadvantages. When advantages are you save a lot of time. You don't have to build it from the scratch. The group is already there. For example, a group which goes to church every Sunday in one particular church, you go there and you talk to them. If they're interested, there's existing group. You save a lot of time because the group is already there. And an existing group has very often has a experience of working in the community. They know that, okay, this may work. This is the place where the fundraising will work. This is a place where there are patients who will be sort of coming to you. And the community also knows the group because these are people who have been active there. And some of the community leaders may be members of this group. And the group may have good influence on the community. So if you choose a existing group, this can be an existing NGO, it can be an existing club, it can be an existing youth organization, it can be an existing group branch of a political party, it can be a religious organization. So there are some advantages. You save time, and then they know the community well, and then the community also knows them well. Some of their leaders may be leaders of the community also. This is an advantage, but there are certain disadvantages also in doing this. The disadvantages are the project will appear as their project. Sort of these people see it as, for example, you go to a religious group and they agree to take it up. You get volunteers immediately, but then the local people say that, okay, this is the project by that religious group. So this may antagonize some people. This may keep some people away, and the group, any group working in the community will have some problems with the other groups. So you are aligning with one group and you automatically antagonize the other groups. And group may not have representative from the entire community. For example, a religious group will have representatives from only from that religion and not from the other religions. A political party will have representative only from that political party and not from other political parties. And very often when you work in a group takes up a project, their members' interest will be their prime concern. For example, a religious group will, when they start palliative care, they will look at their own people first. And so this is also a problem. And the marginalized groups may not be addressed, minorities may not be addressed. So these are, so you have to decide between these two, whether you want to move fast, talk to an existing group, seek their support, or you want to talk to different groups or different people and the project it as your project, or like a project it as the other group's project. So it both has advantages and disadvantages. I'm not suggesting that you take one or you do not take one, but you should know the advantage and disadvantage. Then you choose, like depending on your situation, your background, your locality. You may think that, okay, in this particular locality, it will be better to work with an existing group. Or you may think that in this particular locality, this may be advantageous not to work with the existing group because there is a lot of conflict there. So this is something you have to decide. And what do you say? Okay, if you gather a group of people, 10 people come to you, and you want to talk to them about palliative care, you want to get them as volunteers. The message should be clear. The first message is that you are telling them that look around you. There are a lot of people who are suffering. There are a lot of people with advanced cancer, or a lot of elderly, older people, a lot of bedridden people who are suffering. And the second message, you are telling them that, okay, you can help to relieve the suffering. You can tell them that, okay, if you spend some time, we'll train you, and if you spend time, you can help in relieving the suffering. These two messages are clear. But I always insist that the third point is also need to be discussed with them. And what do they get in return? Where if you help this person, you will get something in return. What do they get in return? Any suggestion? Why should they help you? Why should somebody who is not paid, somebody in your area, or somebody like is not a doctor or a nurse, or somebody do not gain anything from it? Why should they help you? Any suggestion? Anything in the chat box?
As of now, nothing, sir.
Yeah. Anybody want to suggest anything? Why should somebody come and help you?
Yeah.
Why should somebody, any person want to become a volunteer at all?
Dr. Shobika sent us chat message. It came to me directly.
Yeah, please,
Sir. She says,
please.
happiness, peace of mind, and satisfaction.
Okay, this may be like when you look at yourself, you will find that, okay, this may keep some people happy. This may give some peace of mind. Okay, you're doing a good thing. You will feel that, okay, you basically are a good person. Anything else?
We may depend on this type of help in our life also in the later part.
Okay, tell me. Yeah, you are Sudesh's Pavan or you are Prashant? But
yes.
How should I call you? Prashant.
Prashant, yes.
Yeah,
now we
Prashant.
are working as a volunteer the same way in our old age also. We need some help like these volunteers for our lives also. So that's very...
Okay. So you expect that if you do something for them when you need some help, but you may get it. But there's no guarantee, Prashant, no?
Yeah, helping to others. So sometimes
but you are not sure. You may get something
yes,
back. Yeah, you're hoping. Anything else?
For
Anything
hoping,
else?
yes.
Yeah. Okay. Anything else?
I think in some countries there are it's like a bank. I mean, if you help, and it will be registered.
Yeah. There'll be time bank or charity bank, and that's making it really formal, very formal. And there are places, some places in Scandinavian countries, some of the places they have
in European countries
experimenting with this. Like you spend say 30 hours this month or 30 hours this year for somebody, and later when you need 30 hours, somebody else may come and help you. But again, there is no absolute guarantee. That's well, you're hoping that somebody would come. Anything else? Anything else?
Yeah, Dr. Shobika
Yes.
again sends a message
Some,
saying that
Yeah, yeah.
volunteers will get to know that what to do if such things happen in their families.
Okay, they may acquire some skills, and some experience, and they would know that, okay, because chronic illness, old age, death and dying are so common that you may come across somebody in your own family who would need it. Okay. Anything else?
Sorry, sir, someone was speaking. Please go ahead.
Okay. Anybody want to make one more comment before I move to the next slide? I have my own. I talked to a lot of volunteers about this. Why do you do this? And then I probe. And then even when they say happiness, why should it give you happiness? And I probe, and then they come out with some answers. I'll show you the answers that I get. I pull them together. But before that, anybody want to make any more comment? All the things that you suggest are really valid. Yeah. Anything else? You missed one key. You did not mention one key thing. There is, yeah.
There are some organizations. There are good things and bad things. Even though the people are telling we are the self-satisfaction and helping to other people, they can for their organization they are raising fund for their organizations, and some organizations, especially the international organizations or some organizations, while they are doing the volunteer work, they can get some tax extensions in the
Okay. Some material goods, some certificates also maybe. This is what.
Also there.
I had asked.
Dr. Shobika, sir, once again, she says that this might be a stepping stone for their future. They might try to go abroad for work in which these would be a plus point.
Actually, some of the young people, particularly the young people, the certificate would be valuable for them. And this is also in addition to the skills that they get, like some of the communication skills. And you still miss something. I'll show you. Okay, 1 minute. Stuck. Yeah. Why? So I have asked a lot of volunteers why they do it, and they come in two categories. Like a lot of people do it because they are not exclusive, both other. But a lot of people do it because they believe that there will be some reward in the afterlife. Like they will say that I'll do this and I'll get my reward from God. I'll get that. So this is important, particularly in Eastern community, Asian and African, Latin American communities and all. This is an important one. Like people would feel that, okay, for the good things that I do here, I'll get the reward. And there are a lot of people who are looking for some reward in this life also. You may be looking for both sometimes. Yeah. This life, the first one you already mentioned, feeling good. End of the day, you feel that, okay, you are not that bad. You are not a bad person. You are a good person, because that will help you feel more peaceful, happy. And then there are a lot of people who look for popularity. You find that, okay, if you do this, your neighbors appreciate you. People say that, okay, this guy is okay. Every week, this guy is going to the old age home and spending 2 hours with that inmates. That's a good thing. People appreciate it. There are people who enjoy that sort of appreciation. Political reasons, like sometimes you may want to stand in the next election, and you do this and people appreciate, and it may turn towards, particularly in the local body election, or you do it as a representative of your political party. Then people say that, okay, look at this political youth wing of this party, they are doing this sort of good work and all. And also the skills learned will be useful in life for this one. So generally, a lot of issues also there, but generally they fit into one of these categories. Reward in afterlife, reward in this life, feeling happy, feeling good, feeling peaceful, people be appreciating it, your neighbors appreciate it, your colleagues saying that, okay, after regular working hours, weekends, this guy goes to the old age home or to the cancer center and support patients. So that is also like rewarding. Political reason and skills used in the life. And again, how do you want to communicate with them? Like when you, because currently we have a lot of options to communicate with the potential volunteers. It can be the best one that I found that the maximum yield, but results you still get from interactive groups. Sit with them, discuss with them, ask them questions, and listen and answer their questions, and then clarify or build some bond over the time. So that one yields maximum result. Lectures may yield some results. You give a lecture on palliative care and need for volunteers, anybody can help. After the lecture, you'll find that 2 or 3 people would come to you and they would say that I want to do this. Some of the events, palliative care days, or some of the campaigns, particularly in institution, and art, theater, exhibition, drama. In Bangladesh, I've been involved in a project where they were doing street dramas, like roadside demonstrations, drama, pamphlets, brochures, other printed material. And online now we have this social media, WhatsApp groups, Facebook posts, discussion forum, email. But something from experience, something that we have noticed is that much better results on direct face-to-face rather than online. If you circulate it online, like the yield is much less than the, but these can all supplement each other. Like you can run you can do a lecture, you can do an interactive group session, and then you can also do a post on the Facebook. You can ask people to share it, share your comments in the WhatsApp group. You can use Twitter. So this is how you communicate. Basically, you are telling them that, okay, the previous communication, whatever you are, whoever you are, wherever you are, you can help somebody in suffering. You can help make a person's life better. And then later you can also discuss that, okay, like whatever be your reason, you may find your own reason for doing that. Whatever be your reason, if you do it well, somebody would benefit from it. And you, as a facilitator, the person who is doing it also, like it all depends on you. It all depends on the facilitator. If the facilitator is not good, like even if they show good interest in the beginning, they wither away. And they may not show interest at all sometimes. So community should have trust in you. They should know that, okay, so best to work in a community where you are known to some people, you have friends there, relatives there, your old classmates there. And then you should have the ability to listen. You are trying to encourage them to become volunteer, but you need to listen to them. What do they say? What do they want? What are the points that they raise? What are the questions that they raise? And also avoid ego. Like though you are starting it, don't think that you will have the privilege. Like tell them that you do not claim any specific advantage. Tell them that, okay, like if there are 10 volunteers and you are also with them, you need to be democratic. You also have one vote. You cannot overrule them. And when not too much of theory, like deliberate, discuss, and like between theory and action wins. Start doing, and then you'll find that, okay, many of the doubts and many of the issues get cleared when you start working it. And you need to inspire people, but there is no recipe. Like you cannot say that step 1, 2, 3, 4 for inspiring. This is something that the way you work, the way you talk to people, the way you address, and then this can be. And a good facilitator is committed to work with the local community. You should have a commitment to work with them. And you need to, again, this is particularly for doctors, this is something that I found. Doctors are very hierarchical very often. And the layperson coming and discussing, asking you questions and questioning you, many doctors do not like it. So, but if you do not like it, you are not the person to be a facilitator. So you should be willing to give up control, discuss, listen to them. And if their point is better, accept it. And you should be ready to share your skills, knowledge, and power. Sometimes you find that the project is slow. Like you get 10 people interested, and then you fix up a training program, only 5 turns up, the other 5 says they would come back later. So this is natural, this is part of the game. So you need to accept that sometimes this can be slow. Be patient and prepared to remain committed for a long term. So this is not a short-term project, because to get the volunteers, to build the trust. Once you find that, okay, people start trusting you, once you find that volunteers are comfortable with you, you'll find that a lot of people come, but that will take time. And there are places where you don't find any result. You start talking to people, you contact people. Somebody would say that I'll turn up, but they do not turn up. And don't get fed up, because then don't blame the community also. You have to review the whole process. When you start working, trying to get volunteers one place and you do not get volunteers, again, review the whole thing. Review the whole thing. What did you ask them to do exactly? What exactly did you ask them to do? And was your message clear and sensible? How did you present it? Was it really clear? And how do they see you? If you are not acceptable to them, if they are suspicious about you, however you try, you may not be successful. Another person may be successful there. So this is the when you do not get enough volunteers, when you do not get the good response from the community, review the whole thing. Review our process. Review the way you have been talking to them, and again look at the way they are looking at you. And yeah, so earlier I suggested that, okay, there are some advantages in working with a single group, and there are some disadvantages also. Over the time, my policy has been to work with multiple groups. When you start with a single group, you tell them that, okay, if there are other groups interested, we'll be working with them also. Don't keep it as a secret, like keep it very open, keep transparent. And also, again, the last point, many of you, I don't know, many of you would agree or not, but this is something that I've been doing all the time. Like we don't exclude the local politicians. People are generally, particularly professionals, are very often suspicious of the politician. But the political society is also part of the civil society. So wherever I have been working, I talk to them, discuss with them, tell them that this is what we are doing. We also ask not a single political party, like it's the spectrum of multiple political parties. So as a rule, do not exclude the politician, because you'll find that this will be really useful at some stage, because they can do good advocacy work. They can be on your side rather than against you. And you will find that there's a political group which is actually a group of politicians who knows what you do, who knows what is political. This will be really useful. So these are the things that I have been following up. And also network with, not necessarily with the healthcare sector alone, and network with the education institutions, network with the churches, network with the other organization. Because palliative care, when you talk about palliative care, you're talking about emotional support, psychosocial support, spiritual support. So anybody in any group can be of use. So you need to find their role. You need to find that, okay, the whole plan of palliative care, because you are not just talking about clinical service. You're talking about somebody helping the patient at home. You're talking about somebody bringing them food. You're talking about somebody supporting the education. You are talking about somebody doing odd jobs for them. So you're talking about somebody offering spiritual support. So when you network, go beyond healthcare, go to any organization, any group. So just ask the question, like, okay, where can you fit in? This is the broader agenda. And when you training, like we all had to do training program for volunteers. And training, again, when you do training, connect with the individual's daily life. Just like not didactic sessions, not sessions or theory. Talk to them, interact with them, ask them what they found out, ask them some of the problems that they faced. they see in handling these patients, and then discuss, make it interactive. And the participants felt need when they come for training, you need to ask them, okay, have you seen such patient? What do you find? Has there been anybody in the family? What are the problems that you faced? And so then if you offer solution, they'll be more keen to learn. And tell people also that what they gain. For example, you run a communication session training, and before the session, you tell them that, okay, this is what we plan to do. This will help you to talk sensibly with the patient, with another person, a patient, or an older person, or a better person. And end of this, you will feel more confident talking to them. You will feel that you are useful to them. So training programs need to be oriented towards the target group, oriented towards. You need to just do not just go there with a curriculum and a few slides and deliver. Talk to them, ask them what they need, and ask them their stories. What have they learned? What are the points that they want to discuss? So that's how it needs to be. And continue the training, even if you have adequate number of volunteers, continue the training program. Continue the training in both sense, because you will find a lot of supporters within the community, and also you will find that, okay, the replacement of your volunteers is easier. And so basically the idea is to build capacity in the community, build people, let people know how to do it. Even if they are not working for you, even if they are not willing to go, they want to, even if they are not planning to work for you immediately, train them, train as many as possible, and use a structured training program with a proper feedback and improvement skill, and never stop sensitization. Like this should be part of the, in addition to delivery of care, this should be part of your program, like regular sensitization, regular training, so that a lot of people, more and more people in the community knows about what you're doing. More and more people in the community are willing to help. More and more people in the community are volunteer. So this is my email address, and this is my, the last slide. The slides, I think Vanilla will share with you. And if you have, we have some time. I think we have 10 minutes now. Yeah. Any questions or anything you want to discuss or suggest? I'll be happy.
Please, we can always you can type your questions in the chat. I'll read them out for you.
Yeah, either in the chat box, or you just raise your hand and so.
Yeah, I see Dr. Suren and also Dr. Jonathan joining. So any thoughts or comments, sir, you can also chip in.
Yeah.
Thanks so much, Dr. Kumar, for that session and highlighting the importance of volunteers and kind of building the community of care in palliative care, because I think volunteers are a really, really important bridge between the healthcare setting and kind of more of the formalized settings that we often work in, and then the community of care that helps to care for people. So they are a very important part of palliative care movement. It's difficult to mobilize them in different contexts, but I know that you have lots of experience with doing that in your settings, and I think it's really good to stimulate some of the participants' thoughts around how to get some of those groups and movements going in their own communities. So I know there's some volunteer activity happening. I think maybe Suren, you can comment more on it, previously related to cane and that kind of stuff on the ground, but I don't know if anybody has any other thoughts around what this could look like in Northern Province.
In Sri Lanka, I've seen some religious groups active in this area, like the I come across some of the Buddhist groups which have been doing this in some areas, and some of the Christian groups doing this in some areas. I think it's coming up.
Any questions, Suren sir? Are you there? Would you like to comment? Or I don't
Saran,
see it, sir. Yeah.
Okay, this
I'm
is
sorry.
So-
I'm sorry.
Yeah, Suren.
Yes,
Suren.
Yeah, I know that because our Cairn Hospice, we got one patient COVID positive.
Mhm.
So that
Okay.
so then now that actually your experience, then the developing, you always ask, then to develop this networking, that mobilizing, and also in our setting that we had earlier very good models, but that these days very difficult to get the volunteers to come and involve in this kind of work. So any best way these people can mobilize, and also then our people need to understand, then even during this COVID also, still we are not seeing any volunteering and then mobilizing that kind of thing here. But you were using extensively, particularly in Kerala, we
Yeah.
were listening.
Saran, I had seen a group in Anuradhapura, Samadhi's team. They involve quite a few volunteers. I've seen it's happening. But again, the other option would be like, even if you are not looking for volunteers in the community, there'll be a lot of people around that patient. Any of your patients, there'll be a lot of people interested in the well-being of that patient around. So if they train them, if you train the family members, the friends, relatives, they can be helpful later also. So this is how in some of the places that we have done. Anybody interested, because there are a lot of people around the patient interested in that particular patient. So if you tell them that, okay, we will tell you how to prevent a bed sore, we will teach you how to feed the patient, we'll teach you to do this, to do that, they may be interested. Some of them it sort of maybe in later interested in helping the other people also. That's also one way of building it up.
And what do you think that about having kind of a regular courses, conducting some regular courses or some training things?
Yeah. We have been running like sort of we run, for example, in my institution, we run training programs for doctors, nurses, and volunteers regularly. Just a structured training program, we announce it beforehand. Fairly good number of people attend also. Like we tell them that, okay, the next doctor's training is on such and such days, next volunteers training is on such and such day. Properly we follow the same proper curriculum, and also give them certificates also, certify. It's a 16-hour training program that we have been following. Fairly good. Now with COVID, we have not been able to do it properly in the classroom, but on online. But that's a very popular program.
So some kind of similar thing that we need to also think
Yeah,
about.
I think that's possible, particularly with younger groups, college students, university people. There'll be a lot of interest.
But that I was observed when I was there, that younger people and university students are involved. But here it's very difficult to mobilize that kind of system. I know.
Once you set an example, the other people will join. The first example is the difficult one. Yeah, I think.
Yeah. Thank you. That and
thank you, sir.
yeah, I also want to hear Jonathan, and maybe that I need to handle this issue now that one patient positive, now that we have to see what to do with this.
Okay, thank you, sir.
Yes, thank you.
Thank you, everybody.
Thank you, sir. Thanks a
Thank you,
lot.
Pranila.
And I'll be sharing your PowerPoint
Yeah.
presentation in PDF format with the participants, sir. Thanks a lot. And it's really great having you with us at this evening. Thank you once again.
Thank you.
Thank you, sir.
Bye, Janardhan.
Thank you so much.
So, yeah. Hello. Yeah. So once again, I think we are done with our first session. So a kind and a gentle reminder to all the participants before we move on to our next speaker and the topic, and a humble request to please turn on your video cameras. It's very difficult because this is entirely online training and there is no interaction, and we cannot see you, we cannot hear you, and requesting please all of you to please kindly turn on your video cameras. Thank you. And our next speaker, we have Dr. Jonathan with us. So, sir, over to you.
Okay. Just getting
Yeah, you can see your
my
screen.
slides. You can see my screen. That's good. Good to see everybody again this evening and this morning here in Canada. Hope you're staying well, and it's good to see Dr. Kumar and have some of those thoughts around some of the non-medical aspects, but very important aspects of the care that we provide in palliative care. So continuing on this morning, we're going to talk a little bit more about self-care in palliative medicine. Now, this is a topic that we really need to have more discussion about as a group, because I have a few slides to kind of go through some of the kind of some core principles around burnout and moral distress and those types of things that we see in palliative medicine. But self-care is a very collaborative thing, and it's important that you figure out what that means for yourself individually, but also how you do it as a team and within your institution. So it'd be hopefully have some time for some discussion during this session. Let's see here. So a few objectives for today. I want to just reflect and review some of the strategies for self-care and promoting personal resilience as we work with families and patients nearing end of life. We want to understand the signs and some of the preventative strategies for burnout, moral distress, and compassion fatigue, and to understand the importance of self-care from a personal healthcare team and organizational perspective. So we have a few questions to think about, and there's many other questions to think about as we go through this. Maybe we'll have a bit of time for just brainstorming and discussion now, and then we can go through some of the presentation and have some more time for discussion at the end. But I'm also very sensitive that self-care looks very different for different individuals, but also in different contexts and cultures. So I'm really curious to hear, when you hear the term self-care, what do you think of when you hear that term?
Please do respond. You can also type your answer in the chat.
To
It'd be really
maintain,
nice if you, oh yeah.
yeah, to maintain the physical and mental well-being of the individual.
Okay, that's good. To maintain your physical and mental well-being. Yeah. What types of activities or things do you think of when you hear the term self-care? What does that bring anything up in your mind, or? Are there any practices in particular that you find helpful for yourself, or?
Shobika says educating patients. Dr. Shobika, I don't know in what context. She says self-care is educating patients.
Self-care is educating patients. Usually when we think about, I mean, self-care, it's more about caring for the practitioner and the teams themselves, so ourselves. But you're right that part of what we do in palliative care can be educating patients and oftentimes families and caregivers around how they care for themselves as they care for the patient who is declining. So teaching self-care principles to family members is also important. There's a few other questions that we'll come back to as we go through things that I just encourage you to think about in your own work context. Is what are the barriers that you face to self-care in your practice? What helps you be able to do self-care in your practice, and what does this practically look like for you in your work and daily life? And then ultimately, are there any helpful changes that might be helpful in your work context? so let's just go through a few kind of principles around self-care and some of the syndromes that we do see when self-care is not attended to. I think we often think of self-care as a very ambiguous, abstract concept. I think we all feel pushed in our work and stressed in our work, but it's important to be aware that there are some more defined syndromes and patterns that we do see in people as they work in very emotionally and physically demanding jobs. And it's important to just be aware of these things for yourself and to monitor yourself for these symptoms and adjust accordingly as you need to. So the first syndrome that we think about is burnout. And I'm not sure if this is a term that's common in Sri Lanka or if you have a different word for it. I realize there may be different terms for these in different countries, but have people heard of burnout? Is that a term that people are familiar with?
Yeah.
Maybe shaking heads. Yeah. Okay.
In Sri Lanka
So-
also, we are using the term.
Okay. Okay. Good. So burnout means a lot of different things to different people. One way that they look at defining the syndrome of burnout is these three spheres. So it's losing enthusiasm for your work, getting emotionally exhausted with going to work, moving towards depersonalization. So that's where we start to treat people as objects rather than as humans and as emotional beings. And then the last part is having a sense that your work is no longer meaningful and a lack of personal accomplishment. And as these three things start to grow over time, they can certainly feed on themselves and cause many problems both at work and in our personal lives. There's many signs and symptoms of burnout. I've just listed a few here to kind of be aware of and think about. First being overwhelming exhaustion. People describe feeling cynical or detached from their job and lack of job satisfaction. Sometimes people start to withdraw socially from other relationships, questioning the meaning of life or other prior beliefs that they had. Addictive behaviors can be a result of burnout as well, and we certainly do depression in varying degrees. Avoiding emotionally difficult situations can be a result of this, and that's particularly challenging in palliative care as a lot of our work is inherently emotionally difficult. So interpersonal conflicts can arise either with family members or friends or certainly within the team environment. And then people can develop more perfectionism, rigidity, irritability, or hypervigilance. So those are kind of patterns that we might see in people that are becoming more burned out. There's a lot of also contributing factors to burnout. I think a lot of people think about workload as being primary. Obviously, you guys are facing a lot of heavy workload these days with COVID, and some of you may be feeling a sense of burnout because of that. So that is a factor. Sometimes we have some control over workload. Sometimes when the pandemic rolls around, we have less control over workload, but that's certainly a contributing factor. Having a sense of control is an important factor in trying to mitigate burnout, and also proper training. People that feel overwhelmed and that they don't have appropriate skills or training are much more likely to become burned out. So education is an important piece of trying to prevent it from happening. Good team functioning and conflict management within the team is really important. So conflict and difference of opinion is inevitable whenever people get together and work in team. But the most important thing is having an atmosphere that allows for communication and for those conflicts to be worked through in a safe and respectful manner that honors everybody's contribution in the team. Values can sometimes not aligned with palliative care. So either that's the individual doesn't really believe in palliative care, or the institution sometimes doesn't value palliative care and work, and certainly that can lead to a sense of being demoralized and devalued. Reward is an important part of mitigating burnout. People need to have adequate monetary compensation for what they do, and also personal satisfaction. And then we talk about emotion work variables. So that's kind of how your work triggers things for you. And that's a common part of working with people that are nearing end of life. And then there's a lot of extrinsic factors. So that's factors outside of your job that happen sometimes without your control, whether it's a personal health situation or family situation or other societal events. So those are just a few factors that can be contributing to burnout. The next syndrome that's kind of related to burnout is called compassion fatigue. And it's more of how we think about the emotional impact of working with people that are involved in traumatic life events. And in our kind of work, that's really terminal illness. Compassion fatigue is the term used in other types of work as well, social work, and working with other marginalized populations. But certainly in our case, we work with a lot of patients that are facing very traumatic events themselves. Compassion fatigue has often been described as kind of a form of post-traumatic stress disorder, where we as care providers witness things that are very distressing. And some of the symptoms of compassion fatigue can be quite similar to post-traumatic stress disorder. So people can become hyper aroused, have difficulty with sleep, very vivid and disturbing dreams sometimes, and intrusive thoughts. That can be, guilt about how they weren't able to respond to a certain situation, anger about a situation, and then sometimes also leading to hypervigilance or even avoidance of situations. And over time, this can either lead to people becoming over-involved in relationships and leading to even further burnout, or becoming emotionally attached from relationships as a kind of defensive mechanism to try to compensate for this. So in terms of thinking about prevention strategies, we often, for burnout and for compassion fatigue, it's helpful to categorize these into personal strategies, professional strategies, and organizational strategies. So maybe just have a bit of brainstorming from the group. Can you think of any personal strategies you find helpful in terms of preventing and managing burnout for yourself?
Relaxation methods.
Yeah. Go ahead.
Personal relaxation methods.
Relaxation.
Relaxation, exercise, meditation, and regular exercise. Healthy food habits.
Yeah.
And reading and good habits. We can maintain good habits and those things.
Yeah. Those are all good ideas. Any other strategies or thoughts from other people?
Recreational activities like playing games or something like going out, having trips.
Yeah, being able to get away from work, playing games, very good.
If it is more than a normal level, they can get some support from some professionals like befrienders, counselors. So they can talk, they can listen, they can discuss their problem.
Yeah. You mentioned meditation. Is that a common practice, do you think, for people in Sri Lanka, or
Yeah.
or for doctors and nurses in Sri Lanka, I should say?
It is not common, but
Should
it
be
is
more
not very
common.
Yeah.
Same in Canada. There is a lot of discussion and interest around the idea of mindfulness. I'm not sure, is that a term that you're familiar with?
Yeah,
Mind-
the mindfulness.
mindfulness.
Yeah, it is in past and it's the organizing the past and future. Yeah, organizing the past and future future things at a time. That is the mindfulness. Sometimes our thoughts are always around the past incidents or future incidents. We have to organize the thoughts
In the present, yeah. Yeah.
in the present.
It's
Yoga also now in the India, a country like India and Sri Lanka, some activities like religiously related activities like yoga and these things are there as relaxation method.
yeah, well, that's all helpful. And I must say, some of the strategies from Asia, South Asia are certainly making their way into North America and Europe, and things like yoga and mindfulness and those types of things we're appreciating the benefits of them here as well. So I think part of the reason that mindfulness is becoming more of interest in professional organizations is because our world is becoming very fast paced, and the information is very fast paced. We're often on our phones. We have many things to be distracted by all the time. And it's important to develop routines and rhythms in ourselves that help to, calm anxiety and restlessness in ourselves. And when we are feeling more emotionally worked up, be able to have strategies that help us to center ourselves again. So I can't tell you exactly what that's going to look like for yourself, but all I can say is that you're going to need to have some sort of strategies to be able to manage with the stresses that come across with caring for end of life situations. So just a few of the personal strategies that we think about. There's many. We've talked about several of them. So obviously adequate sleep, nutrition, exercise, and developing a specific set of coping skills within your own job. So good time management, and like we talked a little about, cognitive restructuring or mindfulness, those types of things. One thing in palliative care that I think is important to remember is finding time to grieve losses. There are some cases that we come across that are particularly emotionally intense and may touch your soul in a more personal way. And so I think taking time to recognize that and to grieve those losses, maybe having a colleague or family member or friend or someone that you're able to speak with about how that's impacted you, is important for your own healing. And that's part of the challenge in palliative care in preventing birth, being emotionally present and obviously caring for people as humans in a time of great suffering, but also setting boundaries enough to not carry things home with you all the time. And so that's a constant balance that we all face working in palliative care. We talked a little bit about psychotherapy or counseling, and certainly spirituality, a big piece of how many people cope with the stresses and emotional distress that they see. Self-awareness techniques, so that would include things like mindfulness techniques, and also monitoring for becoming over-involved. So like we talked about, setting boundaries on how you become involved with patients. In terms of professional strategies, this kind of relates to our role in our job itself and our own professional development. They talk about remembering who owns the problem. And so again, we are seeing a lot of patients with many different issues and problems, and we want to do all we can to help them with that, but we need to not take all of those on ourselves or become unmanageable. Conflict management, we spoke a little bit about earlier in terms of managing that within the team and team dynamics. Sometimes there's particular personality challenges within teams that just don't work well together, and sometimes acknowledging where the sources of conflict come from and how to be able to work together is very important and therapeutic for the team to move forward. We spoke a little bit earlier about maintaining a high level of clinical knowledge is helpful for preventing burnout. So if people are feeling like they're not trained in an area or not having adequate skills in an area, and they're being pushed beyond experiences, then that certainly can contribute a lot to burnout more quickly. Having other peers to consult and share decisions with is very helpful. We spoke previously about boundary setting, and diversifying workload can also be helpful for preventing burnout. Sometimes if people are in the same narrow focused job for a long period of time, then it can contribute more to burnout. And then ongoing educational activities. From an organizational perspective, I'm not sure how your organizations help you with these topics, but I think it's important to make sure that your organization acknowledges that these things exist, because that's the first step, is that burnout and compassion fatigue are a real thing. And they really need to foster a community where people have openness for communication and to be able to express their stresses. The common thing within palliative care teams that can be helpful for this is to have debriefing of challenging cases and case discussion for cases that were particularly emotionally or ethically intense. How do you find your organizations and hospitals that you work in support you in preventing burnout or acknowledging burnout? Is this a thing that's talked about at all in your setting, or?
No one wants to comment. So everyone is so quiet.
Yes.
So please just share your thoughts or like comment so that like we can make this session some interactive session.
Actually, in Sri Lanka, organizational level, there is no much support in preventing burnout, because we are sort of staff, and our economy also I mean, as we are developing countries, so we
Mhm.
don't get much. But there are, I mean, like CMEs like that, or some kind of training station. They are nowadays they are implementing. So I hope
Mhm.
in future we may get more support from those.
Okay. Is there like, have you, maybe you've experienced burnout yourself, or you've seen a colleague that's experienced burnout, or if you're concerned about a colleague that's burning out, how would you kind of approach that situation in your work situation?
Normally, if they work, they feel burnout, they go for a holiday. In
Okay.
that's I think that's normal.
Yeah.
Rather than
Yeah.
that, I don't think. So sometimes, like a sessions we are arranging as a colleagues, so we can get the knowledge, and same time we can spend the time leisurely. So like those kind of things we are doing.
Yeah. Do you feel like there is the ability to talk to your bosses and administrators about these issues, or is it kind of not something that's talked about very much in Sri Lanka? Is there openness to talk about it?
Yeah, we can talk, no problem, but
Okay.
can talk.
Okay. Good. Well, that's a big important piece of managing these things, because sometimes there's organizations and institutions that don't even really address it or acknowledge it, and certainly in many parts of medicine there can be a sense of just kind of putting your head down and getting through it, and being stoic about it, and not expressing how it's affecting you either physically or emotionally. So
But in our setup, they listen us, and because the problem is we are lack of staff, and as we are a developing country, we are financially they can't support. Those are the issues. But as
yeah.
the administrators and bosses got training from the abroad, so they know how to handle. So they help to. I mean, they try their maximum to we come up from the burnouts.
Yeah. Okay. That's good to hear. Anybody else have any thoughts? Yeah. Oh, I think you're on mute. Oh,
Jayarasa sir,
Becky.
you're muted. You're muted, sorry.
The managers are not much worried about this burnout. The managers are not much worried about the burnout. I think in their training, in their training, they should the curriculum should teach them about the burnout and these areas. So that is a issue in Sri Lanka, as Dr. Puvi mentioned. These they are not much worried.
Is it a common thing, do you see in your hospitals and practices? Do you see many of your colleagues
Yeah.
getting burnout, or
Yeah, yes.
what do you think are the main factors in Sri Lanka for people to burn out?
Yeah, as you mentioned already, the low setting, the low resource settings. Many of the institutions, many of the healthcare institute settings are low resource.
Yeah. So workload, I guess, is
Yeah. So but we can overcome the low resource settings
Yes,
by
distribution of the
the
staff also.
teamwork and all those things. If the managers are motivating the staffs, then they can work even with the group work, teamwork. Some units are working with the low resource settings, with teamwork. So it is depends.
Yeah, sorry, I think Dr. Puvi had something to say too.
Yeah, we have, I mean, there are poor distribution of staff also contribute in burnout. In some district and some units, they have well equipped with the staffs. In some units, it's other way around. So those things should be managed from the central level. So that is not in our hand, actually.
Yeah. Yeah. I think it's good just to be aware of these things yourself, and then you can kind of monitor things in your own work setting. And it's true, we're not, necessarily top managers and things like that, but it's helpful to at least bring things to people's attention if you're seeing these as common problems in your organization. One thing I just wanted to talk a little bit about too is moral distress, which can be a common thing in palliative care and also contribute to burnout over time. Have people heard of this term before, moral distress? Anybody heard of that term? Maybe I'm seeing a few head nods. So moral distress is something that we can often experience in healthcare, and it's particularly common in palliative care because we deal with a lot of ethically sensitive topics. And it occurs when a clinician has their own personal belief, but they're expected to act in a way that's against this belief in their job. And so some examples of this can be if you're seeing that's in an excruciating amount of pain and distress, and you want to provide them with analgesia, but the patient or family refuses this. Another common thing that can occur in healthcare teams is maybe the nurse that's caring for a patient might disagree with the medical treatment that's been ordered for the patient. Maybe they see the patient as in a lot of distress or suffering, or they're being made to have more pain because of the treatment. But the patient's asked for this and the doctor's ordered it, and the nurse is still expected to provide it. And so that can be, a not uncommon thing that happens in palliative care. I wonder if people have experienced that themselves. I think are there anybody experience that kind of personal discomfort in their work between what they personally believe and what they see happening?
Yeah, some religious, some group of people, they against to blood transfusion.
Yes.
Yeah, blood transfusion, but sometimes we need to. The indication is absolutely indication for the blood transfusion with the hemoglobin less than 9 gram per deciliter. Even the family members and the patients are not after road traffic accident or something. So those kind of incidents, I myself personally I faced.
Yeah. How do you deal with that yourself?
That in that this particular incident, the patient with schizophrenia, he was injured in 2010 last phase of war in Mullivaikkal in northern Sri Lanka. That patient admitted to Pavania Hospital and then transferred to Angola Hospital, National Institute of Mental Health, Angola, where the patient two problems. One is relapse of schizophrenia, one problem. Second problem is the cell blast injury. So his hemoglobin level around 6 grams per deciliter. So we need to transfuse the patient. So we need to get we cannot get a concern from patient because he is relapse of schizophrenia. So we should get the talk with the mother, discuss with the problem with the mother. That's a problem. So we had several discussion with mother. Mother is disagreed. 2-3 days we discussed, and finally we ran with the blood against mother's willingness. The patient was safe.
What did the patient think about that when
Once,
was he able to understand it afterwards, or?
Even now, patient under my follow-up. So after 6 months, 3 months, he the patient got fully inside with the depot medication. Even now, we are following the patient, but he's now the patient is realizing that we did that for his benefit. This as a life saving intervention. Unfortunately, mother is not accepting that.
Okay. Okay. Yeah. Yeah,
Mother
we
is
have
not-
had similar.
not having a good-
We've
Mother is not having a good relationship with our team still.
I see.
In Sri Lankan setup, we have Ayurvedic and Western medicine practice. So most of the time, Ayurvedic practitioners are using drugs which are harmful to the patients. So that time also we have the moral distress because we can't blame and we can't do anything. That's the issue in Sri Lanka.
Absolutely. Yeah. We have some similar practices in Canada too, where we see patients that may have very treatable cancers and they decline treatment and opt for more naturopathic or Ayurvedic treatments, and then they come back afterwards with very advanced metastatic cancer, and yeah, it's very, very distressing. How do you process that within yourself? Manage those.
So we explain to the patient and we I mean compare the results. Most of the time the CKD, I mean chronic kidney disease patients go to the Ayurvedic people and come with end stage. So we I mean we compare the investigation results and make them to believe us and like that.
Yeah.
Nothing to do with more than that.
Yeah, I think it's important to remember that it's okay to have difference of opinions, and there's many ways to see a problem, even when we disagree with how people are making decisions. And we often talk about autonomy in medicine and patients being able to make their own decisions, and we can certainly try to guide them and support them, but ultimately patients do need to make decisions for themselves as much as they can. But it is difficult when there's also practitioners sometimes that take advantage of patients that are vulnerable for sometimes financial reasons and that kind of thing. So that can be very distressing as well. So
Dr.
Yeah,
Shobita
well, that's
says, they face this due to spiritual belief as well.
sorry, there's different spiritual beliefs.
Dr. Shobika sends a message saying that we face this due to spiritual belief also.
Yes. Do you have any examples, Dr. Shobika, of that in your practice?
Yes, there was a patient who had a snake bite, and in their religion, they don't go to hospital. So that got severe, and then later on, finally, they came to the hospital where the patient passed away. And a few days later, the wife also had a snake bite, and she didn't go to the hospital, and she was safe. And she came back saying that it was God who wanted her husband to die. Because of that only the patient died, and not because of the snake bite. So she was trying to convince others also it's because of God's will and not because of the snake.
Huh. Yeah. Sometimes we see also people that they don't want to have pain medications because of religious views, or they have a sense of even that suffering is earned or deserved. And so or that it's important in terms of transitioning into the next life to experience suffering and pain, and that can be very difficult to watch, but it is kind of from their own religious beliefs, so honoring that is important as well. Any other comments about moral distress? So just say that there's several sources of moral distress in practice. Usually it's clinical decisions that can contribute to this, like we talked about, sometimes disagreements between physicians and nurses and patients around what the best course of action is. And I'll say that I think nurses really experience this the most, because sometimes they're the ones that have to carry out orders that they disagree with. And just, I think, remembering that as physicians when we're ordering things, and checking in with nurses around how they're feeling about the care of a patient is really important in terms of maintaining team morale. And if these things are left unspoken and not talked about, then it can really build a lot of resentment within teams. So having the ability for nurses to have open communication about things that they have concerns about is important. And it may not end up affecting the care of the decision, but at least being able to voice what the concerns are to try to soften those as much as possible. Resources are a big thing that we've talked about in terms of, the needs being so much greater than the resources available, and seeing people suffer as because of that. Lack of time kind of goes in with that. And then sometimes it's the rules or regulations of a particular institution or place that don't line up with what the person actually believes, that can be a source of moral distress. So just being aware of those as causes. So in terms of just getting back to some of these questions, I think we've talked about some of the barriers to self-care and practice. Can anybody think of any other barriers to self-care strategies in their practice? Talked about some of the managers and organizations not acknowledging it, having time to do it. Sometimes workload is a barrier. Any other comments around that? Okay. I guess I'm curious to know, for this last question around any helpful changes, do you feel like in the places that you work, there would be strategies or ways to change practice that might help mitigate burnout more, or?
Yeah, I mean, in a clinical setup, to reduce the burnout, we can have a regular, I mean, not a meeting, like a sessions. So which could help to one thing is, so we can discuss, then we can build our knowledge. So this will be beneficial to us and the same time the institution. So this kind of activity should be promoted regularly. So this kind of things should be practiced, I think.
Do you have a practice at all there of doing like case reviews as teams? Like sometimes they're called like morbidity and mortality rounds or quality improvement rounds and things like that.
There are those are in place, but not in all the institutions. And
Okay.
so in I mean big like tertiary care centers, it is there, but in other periphery hospitals, that is not there. That is in place, but it is not practiced regularly
Yeah.
most of the time.
Okay. Anybody else have any other comments or thoughts about self-care? It's a very important topic. It's a very hard topic to have as like a lecture presentation, but I think it's important just to be aware of some of the core principles and symptoms and signs to be aware of. And I think the main principles are around self-awareness and self-monitoring, to be aware of the signs for yourself that you may be having signs of burnout, and then really being able to have good communication amongst your team around supporting each other and not carrying resentment around decisions or ways that you're working together. And then certainly having an organization that values the work that you do and helps provide the resources for that. So it is a big topic that sometimes is not really talked about very much or acknowledged very much. So it's good just to have a little bit of time to think about this in your own practice. That was just the reference from the Oxford textbook for some of these points. So, okay, well, we started our session a little bit early. We can end a little bit early if nobody else has any other comments.
Yeah, anyone, like, do you have any questions? There are no questions. So do we have to end the session, or do you want to give any closing comments?
I think that's good for today. I'll just say that we are meeting in the next few days or so, maybe sometime early next week, with the course planning committee, just to kind of be planning the next stages of this course. It is kind of evolving with the COVID situation for all of you as well, and trying to figure out how we help facilitate learning but not overwhelm you with too many sessions. So there'll be more information coming out hopefully in the next week or two around further schedules and planning there.
Sessions which are actually pending, like the death and dying, palliative care emergencies, and setting up of palliative care. So we have these 3 sessions. So not sure like two, Dr. Gayatri was supposed to do it. She couldn't do it like in the previous weeks.
Right,
Try to,
right.
yeah, I'll just try to speak to her and see if I can schedule them for next Wednesday. So that she
That's
can
great. Yeah,
continue.
we can keep those going to finish off the few that were missed.
Yes, sir. So that like maybe we are also having our meeting soon. So if there are no questions, I think we are going to wind up for today. I have shared the feedback link in the chat box. Please do not forget to share your feedback. This is very important to us. And we'll all be meeting next Wednesday, that is 25th August, again 7 p.m. with 2 more sessions. I'll just speak to the faculty and confirm the names of the topics within a day or two. And thank you so much. Please do not forget to share your feedback and have a good evening and good night and good morning, Dr. Janathan, for you.
Okay, thank you.
Thank you.
Thank you. Good night. Thank you. Dr. Janathan.
Good to see you all.
Good night. Good to see you.
Okay.